Thank you so much, Anne-Marie. Can you all hear me? Yes, great. It's a real privilege to be here with you today, and I apologize, my slides sometimes take a minute to go on. And thank you, Katie, for the shout out to IEC. We are very new, but which is one of the reasons we're so excited to partner with Special Olympics in this summit. And who we are is a lot of people like me, people who have spent their careers working to improve healthcare generally and are marrying that with our passion for trying to build a better world for the people in our lives whom we love, who are affected with IDD, and learning that there's a lot of opportunity there. So this is my guy. He's not so little anymore. He's an 18-year-old headed off to college, and his name is Alexander. I always want to point out our challenges and the opportunities in front of us, which actually the speakers who went before me have already touched on quite a bit. But you know, from kind of a national broad view of healthcare, I can tell you what our diagnosis is of the problem, is that we think general healthcare walks around with some very outdated notions about what IDD is. They think it's a small population, that it needs to be served only by highly specialized clinicians, and that most people with IDD are in Medicaid or on disability insurance. When in reality, we know that it's a large and growing population, that there can never be enough specialized clinicians to serve, over 10 million people. And that as a consequence, most people with IDD have to rely on the general care delivery system. And in addition to that, they're often not visible. Not everyone has a disability that's obvious to the eye, and they're not very visible in how healthcare sees its own data, which we'll talk about a little bit. So as a consequence, we've got a system that doesn't really reward clinicians for serving people with IDD well. We have a system where community support from organizations like many of yours are disconnected from what happens in a clinical care setting. And our population ends up experiencing preventable poor health and life outcomes. We need to move on from that. But as Tim alluded to, we're coming at this at a really magical moment in time. It's a ripe moment where not just within healthcare, but broadly, there are conversations about equity and about whole person health. And within healthcare, this new appreciation for healthcare's responsibility to address the social drivers that affect our health. Most of what makes us healthy or not healthy is not what happens in a doctor's office. It's what happens outside. This is the world we're in today, where a preteen like Zoe can suffer from not thriving and get very little help from her doctor, who just doesn't understand what to look for or how to help. He just does, or she just does, what is natural and what is reflexive, which is to prescribe a drug and move on to the next patient. And as a consequence, over time, Zoe and her family lose trust, and they feel isolated, and they don't understand why day-to-day challenges are so hard for her and there's no one to help them. They, if they're lucky, have the resources to go and find the support that they need themselves. They might go and pay out of pocket for specialists to assess Zoe. But all that takes time and effort that not every family has. And in the best case scenario, sometimes, even when they have a diagnosis that makes sense, their PCP or their other clinicians don't do anything with that. And so we end up with the poor health outcomes that we all know about. Part of what's going on is that physicians in particular, but other clinicians as well, often hold negative perceptions. And part of what drives that is that they lack confidence in their ability to help. They've never been trained in it, and their negative impressions are kind of fueled by misunderstandings. And it's way more negative than they feel toward other vulnerable populations like LGBTQ groups or racial ethnic minorities. Another part of the problem, as I just said, is that clinicians aren't well prepared. You know this, we know this. The experts are few in number, and they're concentrated in big, large medical schools and specialized clinics. most people with IDD can't access them. And the reality is, IDD is a lot like diabetes in the sense that it has implications, it affects the care of many other conditions. We know this is true of COVID, we know this is true for maternal health, and as Abby and others have pointed to, and Katie, we know that this relates to obesity that drives conditions like diabetes, heart disease. And yet, unlike diabetes, most clinicians don't get training in care for people with IDD, and they certainly aren't paid for it, so they don't pay attention. The hope is, given this right moment, we really believe the system can change. We know at heart clinicians want to give good care. I went into clinical training because I wanted to solve patients' problems. That is true of every clinician. We also know that healthcare business leaders at insurance companies, in government, who make the new tools, newfangled digital tools that Tim alluded to, they respond to data and to evidence. We also know that healthcare has a lot of money sloshing around in it that could be redirected in better ways to do this work. We know that changing influencers, those people who are thought leaders, who can really drive opinions and hearts and minds, that will accelerate culture change. And we have the reassuring notion that movements like this have been successful in supporting other vulnerable populations. So we know it can be done. So from IEC's perspective, we sort of bucket our goals into 3 areas. Better care, which, what does that look like? It means that patients and families can stop what I call forever seeking of the care that they need. They can walk through any one door and find what they need. It also means that clinicians feel comfortable and competent in doing what they need to do to solve patients' problems. Stronger connections. Now, many of you working in community support organizations, you have a role to play in all 3 of these categories of goals, but especially in this one, because clinicians need not only to connect with other clinicians in order to coordinate care, but they definitely need to partner with, connect with all of you, with community support organizations and with schools to effectively care for someone. And as a consequence, patients and families will feel supported. And what we mean by smarter coverage is that everything on the business side of healthcare is reoriented to support better care for people with IDD. It means better payments. It means that the monies that support home and community-based services and the monies that support clinical services start to meld together as one. And that the signals are sent to clinicians all over the land, hey, we think this is high value, we think this is worth it, and we're going to pay you like that. This is what we think real change is driven by. It's partnerships to produce whole health, whole person health, whole community health through collective impact, because each one of these groups has an important role to play. They're not the same roles, but they all have to work together toward that unified goal. So here's an example of how we can get to better care in preparing clinicians. We have to ask the question, how do we change cultural norms and scale clinical preparedness? And what I mean by that is we have to get beyond doing this one medical school at a time. That is absolutely important to do, but we need to marry that on the ground work with work at a higher level that makes it possible to do nationally. So an example might be creating an action collaborative that includes medical societies, organizations that certify or give licenses to doctors and nurses, government and advocates. And that action collaborative is informed by all of us as caregivers, as patients, as advocates, as well as communications experts who really know how to change hearts and minds. Once we identify the messages that really drive positive will and get clinicians to want to act, then we can adapt training materials, many of which many of you have contributed to reflect those effective messages, and then build programs around that to do what I call grow the demand for the training. There's already great training available. not enough people are asking to have it. And we want to grow that number that are asking to have it. And stronger connections, it's really important to understand that this doesn't happen naturally. Stronger connections really takes deliberate effort. Healthcare can't solve every problem. Healthcare can't make sure that a child progresses in school appropriate for his or her potential. But healthcare can partner with others, with public agencies, with community groups, with schools to get patients what they need. That means someone walks into your office and you see a problem that healthcare can't solve, you have a resource list. You know where to send that patient and that family in the community. You might even make those appointments yourself. You might share information. And through those means, you get to a place where there's one team across the community that's supporting this person with direct support, or helping them to find social connections and activities like exercise programs, or getting them the benefits that they need and the peer support. So one thing that we're doing as a first step is we want to kind of ask the question, well, gee, what should healthcare do? What exactly should healthcare do when it wants to partner with community groups and others? And so what we're having a group of researchers do is to look at a range of care coordination models and find out what were the lessons learned from those experiences, and then produce what I would call kind of a model. Here's a theory about what healthcare's role should be. Once we have that theory, then we can actually go and pilot it and collect data and decide whether or not it's effective, and keep refining it. Once we have that, that is when insurers and government can really step up and say, you've proven it to us. Now we're willing to pay everyone involved to do that care coordination. And in smarter coverage, the early step that we want to take is tackling this problem of people with IDD simply not being visible. When you look in your insurance claims, or when you look in your electronic medical chart, if you can't see the people, you can't help them. You can't measure how well you're doing. You can't get paid for it. You don't know who to pay attention to for what. You're simply going about this in a way that it's like having two hands tied behind your back. So what we want to do is to find a way to make this easier. Can we teach a machine to help find people who might have IDD? And then the clinician can zero in and do that more holistic assessment and diagnosis and figure out what needs this person might have. So these are examples of how IEC wants to dramatically improve health outcomes for people with IDD. And we want to do it in partnership with everyone who has been doing this work for so much longer, because we have the advantage of this perspective of having had to drive big change in healthcare nationally for other groups and in other ways. And we think that those lessons are really adaptable here. And in this way, what we want to do is to amplify all the work that you have been doing over the years. This is the world we want to build, where if Zoe isn't thriving, her family can take her to a primary care provider who really understands. They may not be an expert in IDD, but they understand that this is a case that requires some expertise they can access, perhaps digitally, through an electronic consult with a specialist. And that specialist diagnoses Zoe and tells the insurance company what's going on. Now, everyone sees that Zoe has these issues and these needs in their data. The doctor refers Zoe's family to peer support groups, perhaps to the local Y for group activities, and with the family's permission, shares information about Zoe with her school so that they can assess her potentially for an IEP. Then everyone acts together quickly. They've now formed a team and they're connected to one another. So whenever Zoe experiences new challenges, it's all hands on deck. And the insurance company knows this. They've thought about it beforehand. They've already measured and told people this is what how much money we'll give you to solve the problem, and they give a lot of flexibility for the doctors and the community groups on the ground to do what they have to do. And as a consequence, Zoe and her family feel safe, welcome, and supported, and she does thrive. So this is what we're about, changing cultural norms and working across boundaries. So we really look forward to having you join us in Solutions. Thanks so very much for having me, and I hope you have a wonderful rest of the summit.